My name is Shah. I'm a radiation oncologist. I serve as the director of breast radiation oncology at the Cleveland Clinic. With long-term outcomes from the TARGIT-A trial, the question that has emerged is what is the role of intraoperative radiation therapy in the management of early-stage breast cancer? Intraoperative radiation therapy offers the penultimate in short-course radiation therapy, offering patients the ability to undergo a single fraction of radiation therapy at the time of surgery, with most patients not requiring additional radiation therapy once the final pathology is available. It's important to note that intraoperative radiation can be delivered with several techniques, including electron therapy, which is also known as Elliott at many centers, or low energy, which is often known as target. Additionally, more recently, studies have evaluated the role of high dose rate or HDR IORT in early stage prospective studies. Electron IORT was evaluated in the Elliott study. This study, which was presented with 5-year outcomes, found increased rates of recurrence, roughly 4.4% with IORT as compared to less than 1% with whole breast radiation at 5 years. Though it's important to recognize that this study did not have any form of remedial whole breast irradiation and included a more advanced patient population with respect to pathologic unfavorable characteristics as compared to many other early stage breast cancer groups. That being said, an analysis of suitable patients undergoing electron IORT demonstrated low rates of recurrence, and as such, current ASTRO guidelines do allow for the use of electron IORT in suitable risk patients. With respect to low energy IORT, the TARGIT-A trial evaluated the role of low energy IORT. This study randomized patients to intraoperative radiation therapy or whole breast radiation, with the IORT patients broken down into pre-pathology cohort of patients who received IORT at the time of surgery, or post-pathology cohort, patients who received IORT as a second surgery. In the whole study, roughly 15% of patients in the IORT arm got additional whole breast radiation as factors were determined by the institutions participating without consistent criteria for all centers to be used. Initial studies at 5 years demonstrated that IORT was associated with increased rates of recurrence, roughly 3.3% with IORT as compared to 1.3% with whole breast radiation, which was within the non-inferiority threshold. However, the post-pathology cohort, that group which received IORT at the second procedure, had an increase in recurrence exceeding the non-inferiority threshold. Recently, long-term outcomes were presented for both the pre-pathology and post-pathology cohort. However, it's important to recognize that TARGIT-A has not provided outcomes for the entire group of IORT patients, which raises a major limitation to the long-term findings of the study. The post-pathology cohort had increased rates of local recurrence exceeding the non-inferiority threshold. In the pre-pathology cohort, at 5 years, there was an increased rate of local recurrence with IORT, but it was within the non-inferiority threshold. The authors of the study did not provide 8 and 10-year local recurrence rates with IORT as compared to whole breast radiation. Additionally, outcomes for these pre-pathology patients who received IORT only versus those that received IORT plus whole breast irradiation were not presented. As such, this raises major concerns regarding long-term outcomes and the availability with low energy IORT. Editorials have been raising concerns regarding the long-term outcomes of the study, with some noting that the data available suggests that there may not be any benefit to the addition of IORT to breast conserving surgery. At this time, the American Society of Radiation guidelines do not recommend low energy IORT outside of prospective studies, while the American Brachytherapy Society does not recommend electron or low energy IORT outside of prospective studies. It is important to note that intraoperative radiation, including low energy IORT, has been studied as a boost technique and can be considered particularly for patients who are undergoing oncoplastic surgery where a tumor bed boost after that procedure may not be possible.